Hi everyone, this is Alex from Salmonella Place. Today's pharmacology lecture is on the drug treatment of neurodegenerative disorders. So the first disorder I'm going to talk about is Parkinson's disease. So some of the main symptoms you can see on someone with this kind of disease is bradykinesia, rigidity, tremor, and dementia. The etiology for this disease is unknown. However, it has been linked to stroke and intoxication, among other things. It can be drug-induced, and this is when we have motor symptoms from dopamine receptor agonists. It affects the basal ganglia, meaning that the negrostriatal pathway in the brain degenerates due to the lack of dopamine. So it decreases the inhibitory tone. And this is due to an imbalance between dopaminergic inhibition and cholinergic excitation. Now, the drugs or the therapy that is used to treat this are the following. So we would use dopamine, but that cannot cross the blood-brain barrier. So instead, we use L-dopa. It's taken orally, and it's converted to dopamine as it passes through the gut wall. Less than 1% of this converted L-dopa reaches the brain. So that's why we have to give it in very high doses of 5 to 10 grams a day. And vitamin B6 increases the conversion to dopamine. And just something that's quite important, when you give non-selective MAO inhibitors, if the patient's taking L-dopa at the same time, you can cause extreme hypertension. So that's a drug reaction. The side effects are early and late. The early side effects include vomiting, hypotension, cardiac arrhythmia, anxiety, insomnia, depression, schizophrenic-like symptoms with hallucinations. And the late effects include involuntary movements and the on-off phenomenon. This is when the concentration of the drug in the body gets low before the next dose is administered. So for example, if you took a dose in the morning and a dose in the evening, as it was getting to the afternoon, you would see some of the symptoms coming back as the dose gets low, and then they go away pretty soon after you take the next dose. So it's on and off. Now on to the optimal treatment. This is the now mostly agreed upon treatment, and it's the best way to see the minimum effects of this disease. So we give L-dopa in combination with carbidopa or benzoceride. Now, the mode of action of these are to inhibit dopa decarboxylase. I'm talking about carbidopa and benzoceride. So that L-dopa is not converted to dopamine before it reaches the blood-brain barrier. However, COMT is an enzyme which breaks down L-dopa. So to inhibit that, we use COMT inhibitors, entacapone and tolcapone. We also use MAO inhibitors, selegiline and rasagiline, which inhibit dopamine breakdown in the nerve terminals. Also, amantadine is a dopamine reuptake inhibitor, but it does increase also the exocytosis of dopamine. So it increases the secretion and decreases the reuptake. Other drugs that are also useful include bromocriptine and pergolide. These are dopamine receptor agonists. Their side effects include hypertension and cardiovascular and GI disturbances. However, they are contraindicated if the patient shows signs of psychosis or have had acute myocardial infarction in the past. and atropine and benztropine, which are muscarinic antagonists. Atropine decreases the cholinergic tone, and benztropine is a central cholineolytic. And they treat drug-induced Parkinson's. However, they can cause confusion, memory loss, and sedation, and are contraindicated in prostate hypertrophy and glaucoma. Now, the next disease I'm going to talk about is Huntington syndrome, or Huntington's chorea, as it is more clinically known. This is a genetic disorder, and it occurs when the GABA fibers are inhibited, and that causes hyperreactivity of the dopamine pathways, resulting in involuntary movements and dementia. The therapy for this is using dopamine receptor antagonists, which include phenothiazides, butyrylphenones, and spironolactone. Now, the last disease in this category is Alzheimer's disease. This is a chronic progressive dementia, and it's when the hippocampal cholinergic neurons are destroyed. The therapy includes cholinesterase inhibitors, including galantamine and rivastigmine, which cross the blood-brain barrier, and they increase the accumulation of acetylcholine in the synaptic transmission of the cholinergic neurons. However, their side effects include GI erosion, and they are hepatotoxic. That's all today. If you want to see more of my pharmacology lectures, please go to salmonellaplace.com or one of the links that you can see below.